really a complex case, and what a save indeed. Let's go from Pacific Ocean all the way to Southeast Mediterranean region faculty. Dr. Magdy, diffuse small vessels, CAD and PCI optimization. Dr. Magdy is one of the ambassadors and master of the Society of Cardiac Angiography Interventions, leading a lot of relationships and faculty and junior faculty from Egypt over here. Thank you. Go ahead.
I'd like to thank Professor Samin and Professor Roxana and yourself for inviting me and my fellows to this great meeting. So this dot complication, it's optimization. Those are the, I'm running the Egyptian Board of Interventional Cardiology, and those are faculty who are contributing. Many of them are already in this room. Coronary atherosclerosis is mostly diffuse disease, is at least 50% of the patients. Small vessel disease are among the causes of resistant angina. What are the challenges with such small vessel diseases? Small caliber, sometimes falsely small. You understand that from the imaging. Usually tortuous, angulated, difficult wiring, liable for dissection. And if you have perforation, you may not be able to close. You need certain kinds of stents. Usually distal restenosis is very high, and so it is always challenging. What are the options to intensify medical treatments, to fight risk factors, using imaging, maybe focal stenting rather than extensive metal jacketing of the arteries, maybe BUBA, and recently the drug stents, we are using that, the several developments. This is just a typical case that there is a CX lesion and there is distal disease in all the major coronary arteries. And there is evidence of ischemia in the anterior wall and in the infralateral wall. And so we just sent the CX depending on the IVUS imaging. And we did a drug balloon for the distal LED. Of course, he has also distal CX and distal right coronary. These are the kind of patients with diabetes. And remember that if you put a drug balloon, you prepare the region very well and then end by drug balloon. And so we just dilated the distal lead. And you be careful in wiring and don't overinflate. And then finally, we put along, it's 30 millimeters DCB, and it went well. Of course, it takes 40 seconds to 45 seconds to inflate. This is the final picture. This is a patient 65 years old. He is diabetic, mild renal impairment, edema generalized, and he's complaining of dyspnea, class 2 to 3. He was complaining of this edema and he's not improving until they did accidentally echo for him. He had no chest pain, and they did echo for him, and it was found out that he is having LV dysfunction. Ejection fraction was 30%. I started to see him, and so we did the vitamin echo that revealed it's reversible hypokinesis. The ejection fraction improved with dobutamine to almost 45. The pulmonary pressure was 56, and so the challenge was he's having creatinine that is 0.6. Of course, he was not improving with medical treatments. And so we did angio for him, and this is the angio for him. And you can see that these are like thread-like vessels. Then thinking of intensifying medical treatment, but all this myocardium is reversible, and you may try to improve it. And there's also some calcification in the LAD. And so for this patient, of course, careful wiring is very important. And lesion preparation and imaging would be very useful. And you may think that this could be truly small or it is falsely small. And so imaging may prove it. And since we have DCP, and so you can think of stenting the proximal parts after lesion preparation and then just doing balloon DCB for the distal parts. If they are still stenotic, because after improving the proximal, sometimes what looks very bad distal runoff it improves. So this is after the balloons. And the other thing is the landing zone. If you are putting, if you are stenting these arteries, you need to know where to stop. FFR may help you, but not very much. And IVUS is important. So and stenting distal to proximal. And then you need to address when you come to the left main, then you will decide first what we'll do with the CX. Maybe you can stent the CX before addressing the left main CX. So this is the LAD. He had just distal diffuse disease that didn't need anything, and then we worked on the CX. And you will be astonished that the final stent, of course, avoid long stents in such diffuse severe disease. So we prepared the region more, and then we put 2 short stents. This is the first one, and this is the second. And you'll be astonished the image of the arteries after recanalization, after improvement. It was like this. I assure you that the heart failure disappeared. The ejection fraction was 40, and then after 6 months became 50, and the patient is still alive and doing well. No more chest pain. This is the last case. It's double bifurcation, and you have it's LAD and diagonal, and both are very small. And this is the beauty of having a drug balloon for the branch and stenting the main artery. So and this right also is diseased. And the caliber of the vessels is less than 2.25. So we dilated both the LAD and diagonal, and then we put DCB for the diagonal, and then we worked on the LAD, and it came up to the left main also that it needs to be treated. Then we used imaging to decide is it falsely small or it is truly small. We did that for the CX and for the LAD. I will just jump. This is the imaging. And then we stented distally in the LAD, and then provisional stenting for the LAD to left main. No. And the imaging showed that the CX origin is normal, just mild disease.
A lot of detailed work in these cases.
Yeah.
No question about that.
Yeah. You remember that PCI is an art. If you cannot draw, you should not be an artist. Finally, we just put, he's right.
Yeah.
You can make a shift of the career. So this is the final picture.
Very good.
Yeah.
No shortcuts. I know it's a very long cases. You think you're going to shortcut, and then you don't get a good result. Turns out you have to go all the way.
Yeah, thank you. And
Great, Ahmed.
I invite you all to our meetings in Egypt. Thank you.